Hello, everybody, and welcome to another episode of our Fighting for the Soul of General Practice podcast series. As always, I'm joined by Doctors Rupal, Shah and Foell. Ru and Jens, it's wonderful to have you here again today. Thanks for joining me.
Great to be here, James.
Well, as well as Ru and Jens, our guest today is Dr. Suzette Woodward, a leading patient safety expert in the UK with over 40 years of NHS experience, including more than 20 years focused on patient safety at both national and international levels. Suzette, thank you so much for joining us today. It's wonderful to have you. And how are you doing?
I'm doing really well, thank you.
Well, thank you again for joining us. It is a real pleasure to have you on, and I'm really excited about today's topic. So, without further ado, can I ask you a little bit about your career, who you are and what you do? So to start, perhaps you could tell us a little bit about your current roles and what that work involves.
Okay, so my current roles are quite varied. I'm a visiting professor for Imperial, so I have some research at Imperial College, and I also look up to PhD students and people like that who are absolutely adorable. But I also actually go around both nationally and internationally in advising people in terms of creating their patient safety strategy. And I'm focused very much on things like safety 1 and safety 2, which I can explain what those actually mean, along with developing something called a restorative just culture across the NHS. That's pretty much what I do, but my background is very much in healthcare. I'm a paediatric intensive care nurse. I did that for a good 20 years and have worked in trusts, in government, for Secretaries of State for Health and the World Health Organization and all sorts of places.
Wow, well, you're certainly qualified to speak to us today. Thank you again so much for being here. And I just want to ask you, what first drew you into healthcare?
So I was at school, I had no idea what I needed to do, but here comes the tradition. My grandfather, my aunt, my mother, my father, you name it, they were all either doctors or nurses. So it seemed rather inevitable. But from day one, I knew it was for me. Day one, I absolutely loved it.
And how about patient safety? Did that come later, or were you always kind of interested in that as a topic?
So patient safety in my day wasn't even called patient safety. It was called clinical risk, which none of us particularly understood what on earth that meant. But I was involved in a clinical incident where one of the children I was looking after received 10 times the dose of a drug. And I wanted to know why. And that sparked an interest in trying to figure out what is this stuff that goes on that we don't really talk about very much, because we absolutely didn't in the 80s and the 90s. And I was incredibly fortunate that I was able to do a master's in the subject. And once I'd done that, I thought, well, that's hooked me. This is going to actually take my clinical expertise plus this whole fantastic world of safety science, and I can join the two. And again, it was an absolute joy.
Well, thanks for sharing those stories with us. Now, you've mentioned safety 1 and safety 2, and the NHS is full of, a bit like publishing and education, it's full of acronyms and various other bits and pieces. And some of this jargon our colleagues in the medical profession will obviously know, but some of our listeners won't be too familiar with what safety 1 and safety 2 is in the context of the NHS. So could you just explain the key differences as you see them?
There is an interesting thing in terms of, you're absolutely right with jargon. And sometimes what I try to do is actually talk to people about it without using that terminology. But equally, when you've got other people who are very interested in safety, their knowledge around safety 1 and safety 2 is such that they want to know more in those terms. So if I wasn't using those terms, I would talk about the fact that our approach to safety since around about the late 1990s till around about 2013, it's quite specific, was all thinking about where are we failing, what are the incidents that are happening, can we find the problem and fix it? And that'll be very simple, won't it? And then once we've got these incidents, we will then be able to investigate them, and we'll use something called root cause analysis. And then we'll get all of these guidelines and protocols, and they'll tell everyone exactly what to do, and they'll all follow them, won't they? And it was very kind of bureaucratic and rigid. And yet we relentlessly carried on thinking this is going to make us safer. But shockingly, it didn't, and it hasn't. And the same things are still happening. And so we had to ask ourselves some really difficult questions around about 15 years or so. And those difficult questions were, do we continue doing this way of safety? Is there another way of doing safety? And what would that look like? And we realized that actually the approach, which has been coined safety 1, is incredibly negative. It's negative, it's bureaucratic, It drives fear, shame, guilt, all of these horrible, horrible words, and actually doesn't create nearly as much learning as we imagined. So let's roll on to round about 2013, when somebody called Eric Holnagel, who's a risk resilience engineer, a fancy title, always wanted one of them, and he's worked with a number of safety experts across the globe. And his thinking was being refined and refined and refined. And he wrote what's called a white paper, which described safety 1 and safety 2. And he said, safety 1 looks at failure. Safety 2 is asking ourselves, what's going on the rest of the time? A really lovely analogy for that is, and this was coined by somebody called Merritt DeVos, if you want to study good marriages, you don't just go and have a look at those that have divorced. You actually also ask the people who've got a good marriage. And then you join that information up. So then you get a rounder picture of what marriage looks like from kind of the ups and the downs of both of those. And so what he says is that more often than not, things go right than they go wrong. And so, but we're missing that learning. And if we don't have that learning, we've got an unequal understanding of what's going on in our organizations. And so in order to actually understand safety, we want to understand how it is maintained, how it continues to be safe, and how actually healthcare practitioners can do that despite the systems they work in, the unachievable rules and protocols, despite everything that's thrown at them, they actually can maintain some safety. So that's what safety 2 is all about. It's trying to understand how our systems function safely.
Thank you, Suzette. I'm going to bring in Jens here. Jens, what do you make of that? And do you see any sort of similarities with Era 2 and Era 3, which are, of course, issues we've discussed during other episodes in the podcast?
Absolutely. I'm thrilled by hearing this. It makes me question, it makes me wonder what creates trust between people. That's the core question. And with safety 1, I see fear as the main thing. It shouldn't be with me. Everybody, the culture of blame, finger pointing, writing datixes, having meetings, documenting them, stating lessons have been learned, but they have never been learned, and kind of undermining trust, going for a risk, collaboration, etc., etc. So I'm longing for this way of teamwork that embraces a challenge or can work more communicatively in saying we are working together. We are care people. We are extremely emotional people. We rely on trusted relationships. What can we do to support these relationships? Because that's what creates safety or care for patients. And you cannot be perfectly right and super safe. It comes with a price, probably.
Ru, let me bring you in here as well.
I'm also wondering, Suzette, if you think this is linked with phronesis, practical wisdom. I've been reading quite a lot of Sabina Jamil's work on phronesis within medicine. And it seems to me that safety 2 is linked with that, in the sense of kind of supporting people to be able to make the decisions about how and what the right decision is at that particular time for the person in front of them, accepting that there's a risk with everything we do.
Yes. I couldn't agree with more. Both of your comments are just beautifully articulated, and the problems that we have, but also some potential solutions. And I think that what you've just described in terms of wisdom and judgment is often weirdly not seen as important as following these protocols and guidelines. And I have a lot of people saying to me, especially in very, very senior positions, yes, but we wrote the policy and people should just follow them. And so then when I start to explain that the fact that healthcare is a complex adaptive system, and then they, what's she going on about? I work with a lot of other high-risk industries, and the vast majority of high-risk industries are not as complex as healthcare, and it's not an excuse, it's just a fact. And they're much more linear than we are. So, you have a production line, you have parts at one end and a washing machine at the other. Within healthcare, you cannot have that. You can have pockets of it, but you cannot have that right across. So what we've got is a scenario of a complex adaptive system, but we can break that down even further. And we can say in some instances, we have ultra safe system, which would be like your chemotherapy or your radiotherapy, where we do want to follow some of these protocols to as much as we can. And then we've got high reliability areas where we know that there are risks and we're going to take those risks, but we're going to use our judgment and our skill and our expertise to minimize them as much as we possibly can. And then we have ultra adaptive, which is actually the GP scenario, which is where you don't know what's coming in the door. You don't know what you're going to be doing with the person when they come in the door, and you have a conundrum in all sorts of ways of, do I wait and see what's going to happen here? Do I refer them to somebody else? Do I get them to come back? Do I go to, send to tests? You've got all of this going on in your brain in a very, very short period of time. You cannot have all of these, just hold on, pause, I'll just bring down this guideline that will tell me what I'm going to be doing. You have to use your judgment, and therefore anyone who's running an organization, wherever it be, has to understand these differences, because if you don't, you will judge people based on what you perceive their world is like. And so you will say, oh, we all work in an ultra safe system, don't we? Which is not true, but they'll judge people on that. But if we understand that people work in maybe an ultra adaptive system, then you can be compassionate. You can say, I'm going to be kind, and I'm going to just simply ask, why did you do that? And instead of just, punishing you for not following. So understanding your systems helps you be wise, helps you make your judgment, and helps others understand why you made those decisions.
Suzette, I wonder if I could give you an example of a dilemma that happened in our practice recently, and wondered if you could kind of apply your theories to how we should approach that as a practice. So it's a very simple example. Someone who's on our severe mental illness register, but not known to have physical health problems, although he may well have, wanted to join the gym, and there's a special scheme for people with severe mental health problems. But in order for him to access this, a GP has to sign to say that it's okay for him to go. And what had happened was that a GP had seen this and said, no, he has to come in. He'll need to be assessed. I'm not signing it otherwise. And it kind of ended up with a delay of several months. He didn't come in. And, I'm bringing it up because it feels quite representative of the type of problems on a kind of micro level that we face in general practice. And it feels like a very strong influence is it's not the conceptualization of risk. It's not safe for me to sign something saying he can go to the gym. He might drop dead of a cardiac arrest, even though when you're thinking about relative risks, it's highly unlikely that that's going to happen. And it seems much more risky that he doesn't go to the gym, for his mental well-being, for his physical well-being, all of it. So I'd just be really interested on your thoughts about that.
I really like that example, really like it. And my training is always taught in the safety world, safety science is always taught to ask why. So rather than go, well, the GP wouldn't sign it off, why? Or wouldn't sign it off until they've done some sort of risk assessment. And I imagine the why is because of, as has been spoken about, this massive fear. What's going to happen to me if something does happen? And that could result in so many things. We've got regulatory industries, we've got your Royal Colleges, we've got the threat now, which seems to be more frequent, which is things like manslaughter charges and, and the police getting involved. There's a huge amount of pressure. And also we'd want to talk about the expertise and experience of this particular GP, but that pressure pushes people to make very risk-averse decisions. And that risk-averse decision, as you quite rightly said, could actually cause more risks as a result. So the very fact that you're risk-averse and you've got this delay, as you so beautifully said, the mental health patient actually may be significantly impacted by not going to the gym. And so all of that we need to sort of release people from this fear. And we need to see risk assessment, risk management, risk registers as helpful tools, but not ways in which you can tie everyone up in knots and get really fearful about. So I think that's a really brilliant example of what's stifling us to actually be the brilliant clinicians that we possibly can be.
So how can we get released from this fear? The fear is personal, if it's me and I put my head on the block by recommending something that is risky, and B, it has consequences for the organization, inquests, this and that. Where does this culture shift come from?
So the culture shift comes from a kind of sea wave, as it were, of everyone getting on board with all of this. And getting on board with that means people need to understand more. I don't think they actually truly understand clinical risk as much as they might think they do. And I'm not saying training is your answer. I'm just saying it's one of the components, because if training is just the answer, that's not. It's just one component of what you might want to do. But raising awareness about all of these issues and why people make different decisions and so on is incredibly important to get people to start to understand what are we all trying to achieve. And if you then say, so there's a woman called Amy Edmondson, she talks about teaming, which is where you start to ask yourself, what's our purpose here? So if our purpose for that particular patient was to improve their mental health, and the solution, the treatment, is the gym, that's our purpose. How can we best do that in the quickest possible way? And if we share that purpose, then we'll understand that with every decision we make in healthcare, there are going to be risks, but we will understand that. And then when it does happen, what we want is that restorative just culture, which again, people are not implementing as well as they should. Now, a restorative just culture is where you accept that human beings are fallible, you accept that people make mistakes, the very best people can make mistakes, and you treat everyone with respect and dignity and kindness. And then what you do is you actually respond in a way that is very supportive and understanding. And you always ask the question, why? Not, how on earth, Suzette, did you make that decision? That's ridiculous. It's always, why did you do that? I just want to understand. And if we create that right across the NHS, no matter what care setting you're in, we will go a long way to reducing and shoving out that fear that everyone has.
Suzette, that makes me think of Schwartz rounds for everybody.
Yes.
And I can easily relate to instances where it hurt me a lot to see that something went wrong, a patient with learning disabilities. Why do we so often speak about people with learning disabilities in this context? Went to hospital and died on the ward. And I've done everything. I referred her, I called the people directly. In hindsight, I know I made a mistake. My mistake was sending her directly on the ward, thinking that's a place of safety, but it wasn't. She should have gone to A&E. The hospital were very upset, thinking it was my error. There was a kind of mini inquest and everything fiddled out in nowhere. And for me, there was this desire to come to terms or to speak about it, because there were far more people involved than just me. And I think that's often, unfortunately, we have datixes and this and that, and I rarely see something emotionally reconciling, like a truth and reconciliation committee in Mini coming out. I really want to see this again. To finish this, I'm in our practice the person dealing with the complaints as senior provider. That's a thankless and horrible task, because I'm constantly judged as if everything would be a linear, logical system, all with the benefit of hindsight. And I see different judgments or mishaps, Swiss cheeses, everything understandable, but not looked at with a restorative mind frame.
Mm-hmm. I mean, a restorative mind frame is so lovely. You can't restore somebody back to kind of, as they were before, but it's all about healing. It's all about, as you mentioned earlier, relationships are fundamental for safety, fundamental. And that's both with across clinicians and across all members of the healthcare team, plus our patients and their families. And to restore that relationship and that trust is what we're aiming for. But your story reminded me of, I worked at a hospital where we had a child who died as a result of a vincristine error, which is where you inadvertently put vincristine into a child's spine, and they are often paralyzed and then they die. The reason why I'm bringing that up is that the two junior doctors involved, one who prescribed, one who administered, were charged with manslaughter. And we were horrified by this. And we, as you rightly said, felt very strongly, because with our safety knowledge, knew that nothing happens in isolation. There are going to be lots of contributory factors as to why this went on. So what we did was we did a massive organizational review and investigation. We even recreated the whole incident, and we created a very detailed report, not only for the police, but for the judge who is going to be starting to hear this case. And I'm proud to say that the case was thrown out of the court because of our report, and with the judge saying this is not two junior doctors' fault, this is an organization that let them down. So these are the things that we need to understand. We need to share our stories so that people can understand what it feels like and what we're doing to people as a result.
As an outsider, it sounds to me like there's maybe not enough care and attention given to the health and safety of the GPs involved in this, or the doctors in general. Is that fair to say? And do we need to put more focus on the health and well-being of doctors? Because it seems, again, like the kinds of challenges that you're talking about and that you have all faced are not the kinds of challenges that most people in most of their careers would normally encounter throughout their entire career. And I imagine this is the kind of thing that you may be involved in more than once.
Now, I'd kind of respond to that, James, by saying, yeah, that we should definitely have more compassion within our systems, but also I'd argue that there should be more challenge, because I think that how we respond to significant events or things which didn't necessarily go brilliantly is to kind of stick purposefully on to a surface level. You know, did I make the referral on time? I did. Tick, I'm exonerated. We don't dig deeper than that generally, because it's really uncomfortable and it's not set up for those kind of conversations. So I think that we need to be challenging ourselves more, but compassionately. It's not about individuals. This is about a team, about being part of something. And I don't know how you get to that point. I love Suzette's idea about meetings where you discuss purpose. We're very far away from that.
I think that one of the things that bothers me in relation to what you're describing is that there's an expectation that people should be resilient, that we need resilient people as opposed to actually resilient systems which actually help people do the very best that they can. And if you say that all we want is resilient people, what that actually gets interpreted as is just get on with it. You can bounce back, you'll be fine. Yeah. And yes, we need well-being, but don't translate that into just sort of giving somebody, you know, yoga lessons or something. It is about being compassionate. And there's a whole lovely world of creating psychological safety. I know it's a bit buzzy again, but psychological safety is a really brilliant way in which you can start to have these conversations. Because if you take the 4 steps of psychological safety, which is 1, make sure that everyone feels they belong. The second one being make sure that people can ask questions and learn. The third being that they can then contribute their own ideas and thoughts. And the fourth is that they can challenge and be challenged, which lends itself to what you were saying. Because when you do get challenged or you challenge, you can answer, you can actually explain the decisions you made, which is why I always say with things like policies and procedures, have that caveat in every policy and procedure you have, which is this policy may be adapted or adjusted given the circumstances that somebody faces. If you have that caveat, immediately somebody has to ask you the question, why did you not follow this? I see there's a caveat. So tell me what you adjusted or adapted. Tell me why.
Jens, did you want to come in here?
Out of hours is a very risky environment, often understaffed. And the exemplars for risk in organizations is airline industry or Formula One, and everybody cites them, but I find them not very comparative or useful in comparison, because very often we would say then, we don't have enough people, the service is not working, this aeroplane is not about to start, but what do? We are working understaffed, we are taking jobs on that are, of course you would say that are unsafe, and you take that leads often to moral injury if something goes wrong. That has been, which would be in tennis a forced error. It's not something you make when the sun is shining and everything is nice. How do we deal with this situation of being overburdened or overwhelmed? And we are caring people. We are not saying count me out. This is not safe.
I don't have a magic answer to that one, but what I can say is that you're absolutely right. We looked very early on in the early 2000s to the aviation industry and air traffic control and others and said, you seem to have cracked it, so we'll just do what you do, shall we? And we're not the same by any means. And equally, the things that we adopted from them, we didn't adopt them in the way that they do them. So, for example, they said, collect incidents. Now, if we'd asked them properly, they would have said you only need to collect a few hundred and then you actually start to figure out what's going on. We have millions and millions of them. And as you say, we've got this DATEX system, which is used as a threat. And so I don't think that the aviation industry helps us nearly as much as we think. But then, so moving on to your point around being understaffed and the moral injury associated with that, we know absolutely, and there's an awful lot of research going on at the moment about what went on in the pandemic and the huge amount of moral injury associated with that. The decisions people had to make was utterly heartbreaking. And I know of many, many clinicians who I've spoken to in detail about their experience and how still traumatized they are. And that's an extreme version of actually the daily basis of what it's like to work in healthcare. And that makes me deeply sad. But equally, I need to also have my positive hat on and say, but there is an awful lot of joy and beauty and wonder working in healthcare. But having said that, the things that we need to address are the things that you talked about. And it's too easy just to say, oh, well, we just need to have more money, more staff. It's unlikely to be happening. So it's how do we help people cope with the situation they're in? And so we say things like that power and hierarchy is never going away. The understaffing is never going away. How do you cope with being in that situation? What would be the things you need in order to get through that? And whatever that be, we'll try and figure that through together. So it is genuinely about listening to people, thinking about what their real lives are like, and constantly sharing their stories to the people who are in that world of power who may not understand how utterly difficult it is.
I'm going to bring in my two colleagues here in a second, but can we just take that a little bit further and let me ask you, looking ahead, what changes would you most like to see? Would you most like to see made in the NHS when it comes to safety and creating a more equitable system for both patients and, of course, staff?
I would absolutely love it if we could actually truly understand that the current approach that we're in with regards to safety isn't making things safer. And that's quite a dramatic thing to say, but I want people to really understand that, because until they understand that, we're not. I use the gardening analogy. We've got a really poor soil, and if we just put on a load of new stuff on top of that poor soil, it's all going to die. So you've got to actually improve what we currently do in order to then add on these lovely things like safety 2, restorative just culture, psychological safety. You've got to improve what we currently do. And by doing that, we have to do it well. We have to stop threatening people. We have to drive this fear out and all of those things. So that's what my answer is, let's improve the soil. If you're a gardener, you know exactly what I mean.
Thank you, Suzette. I think that's a really wonderful analogy, and one that this layman can understand anyway. Ru, can I ask you for your take on that?
No, it sounds wonderful. I was going to ask Suzette whether you've got any examples of this working in practice anywhere, that any trust or anywhere in the NHS.
Yes, with regards to things like a just culture, the restorative just culture, there is a trust called Merseycare, and they're near Manchester. And what they did was they were in a bad place. They were suspending people left, right, and centre. They had a very, very, very unhappy organisation and very unhappy staff. And the director of HR went on holiday. There's a reason to this. She took a book with her, which was called Just Culture by Sidney Dekker. And she read it. And she actually says, you will hear her say this if you ever see her talk, that she cried her heart out reading this book and realised that they'd been hurting all of their staff for so long. So she came back and she spoke to the chair and the chief executive of that organisation and said, we need to do something differently. And that's what they did. They turned the organisation all the way around. They stopped suspending staff. They stopped investigating them. They talked to them. They tried to understand what their real lives were like. And they became incredibly supportive. And it is now one of the nicest places to work. So yes, it actually works. And it's not just in the UK. We have organisations in the Netherlands and Norway and New Zealand and others where this is working really, really well. And we're starting to want to share those experiences because when people see things working well, it actually gives them a huge incentive to say, I'd like to do that.
Thank you, Suzette. Jens, you got anything to add to that?
Nothing at all. I think that is fantastic. The soil, that's the metaphor, improve the soil. Everybody can understand that.
Yeah.
I do everything I can in my organization to fertilize the soil.
Well, does anyone have any final thoughts or any final comments or questions while we have Suzette?
Really wanted to thank you. Felt very inspirational to me just listening to what you were saying. So thank you very much.
Oh, it's my pleasure. Thank you.
Likewise, I have plenty of ideas now.
Yeah, thank you, Suzette. That was wonderful. It opened my eyes, my perspectives, and you really kind of made me think about things in a different perspective as well. So thanks for joining us today. It's been wonderful having you on. Ru and Jens, wonderful having you on too. I appreciate your time as always. Thank you all for joining us, and thanks to all of our listeners. We'll see you again next time.